Hello, everyone. Welcome to another VMR recap. I'm Mariana. For those who don't know, the VMR recap sessions happen every Tuesday of each month, the first Tuesday, I'm sorry. And in these sections, we have the Academy members delivering presentations about the VMRs, about the VMRs of the previous month that they chose for some reason because they found it was outstanding for some reason. And today we're gonna have Tansu, Animal Pride, and Gia. I just wanna say, if you have any questions, please just write down in the chat and I'll be reading that out loud at the end of the presentation. And also, I think we can start. We have a lot of people here, so okay, let's go ahead and get started. The first one will be Tansu, and she got really excited with the holidays and chose a really exciting title for her presentation. It's Feeling Festive with a Twist, Unraveling the Stocking Glues. Tansu, could you please introduce yourself, and after that, start to unravel the stocking glues?
Sure. Hi, everyone. Welcome. So nice to see all of you here. My name is Tansu. I'm an international medical graduate from Turkey, currently living in New York. I applied for internal medicine in this match season, and I'm very excited about it. And I will share my screen to get us started. All right. Can you see my screen? Perfect. So on November 22nd, during the RLR VMR, now pre-presented a case, an intriguing case, and the final diagnosis was considered to be CIDP. But later in the Academy VMR's Academy's WhatsApp group, Kirtan raised the possibility of nodopathies, paranodopathies in this patient because our patient's clinical presentation didn't completely align with CIDP illness script. Because when we think about CIDP, we think about a symmetric, both distal and proximal muscle involvement of the upper and lower extremity, and it progresses over a 2-month period. And our patient's clinical findings resembled CIDP, but she also had additional findings of hearing loss and cerebellar signs. And this led Kirtan to the consideration that the patient might have suffering from a nodopathy or paranodopathy that resembles CIDP, but with additional features. And most importantly, it responds differently to treatment. And this is a new group of disorders, neuropathies, associated with antibodies targeting the nodal and paranodal areas in the nerve cells. And this term was first introduced in 2013, so it's relatively new disease entity. And this topic has so much potential to shed light on the mysterious node of Ramvier, but it also carries the risk of, spending so much time in esoteria that I try to keep my North Star of maintaining most of this time in the land of common, in the stocking and gloves, the peripheral neuropathy. And I will briefly mention the nodopathies and paranodopathies at the end. And I will suggest a few articles in my references if you want to learn more about nodopathies and paranodopathies. So let's first remember our patient's presentation, our problem representation. We had a 26-year-old female with a past medical history of Lyme disease, and she was treated 10 years ago. And she also had well-controlled hypertension managed with lisinopril, and she had active cannabis use. And today we saw the patient on a wheelchair. She was unable to walk. She had progressively worsening bilateral, first lower and then upper extremity pain, weakness, and numbness for the past month. And all of these were preceded by intermittent perioral numbness, nausea, and vomiting, and a 40-pound weight loss over the past 5 months. And here's the timeline of our patient's presentation. And up to this point, the patient seems to have a long-standing GI problems and 40-pound weight loss that's preceding the start of the GI problems. And finally, today, when we see the patient, She has a subacute neurologic condition with bilateral lower and upper extremity weakness, pain, and numbness. And in addition to that, she also has bilateral hearing impairment. And when we look at our patient's vitals and physical exam, she has normal vitals and normal physical exam with respect to all the other systems except for her neurological exam. And here are the 7 components of a neurologic exam. Our patient had a normal mental status. In her cranial exam, she had bilateral hearing loss and perioral numbness, so cranial nerve 8 and 5 pathologies, it seems like, and her motor function was decreased in the upper and lower extremities. She also had a hypersthenic sensory exam. Her reflexes weren't assessed, and in examining her cerebellum, she displayed poor coordination with a poor finger to nose test and dysdiadochokinesia. She also had dysarthria, which begins in the cerebellum and goes out to cranial nerves. And she finally had an ataxic gait. But since our patient was on a wheelchair and unable to bear weight, we couldn't assess, the team that was taking care of the patient couldn't assess her gait properly. And in the labs and imaging, the team that was taking care of this patient thought that she might have a neuropathy given the motor and sensory weakness in all 4 of the extremities and cerebellar and cranial nerve disturbances. So they checked all the causes of neuropathy, from metabolic to toxic to nutritional deficiencies, infections. Paraneoplastic causes were excluded with a CT of abdomen and pelvis, and also MRI of brain and spine to rule out occult malignancy. And she didn't get an SPEP or UPEP with immunofixation to check for monoclonal gammopathies, but she got a rheumatologic panel to assess for the systemic inflammatory or immune-mediated diseases, to assess if that could be a reason for the patient's clinical presentation. But all of these tests returned unremarkable. And so what nailed the diagnosis in this patient was the CSF analysis, which showed normal white blood cell count, no oligoclonal bands, and it had an elevated protein with high albumin index, and it showed an albuminocytologic dissociation. And then the diagnosis of CIDP was made. The patient was treated with IVIG for 4 days, and her symptoms started resolving slowly. So one of the first branching points that Rabi pointed out when he was giving his teaching points, when he was delivering the discussion of the case, was differentiating asthenia and weakness. And I think this is an important differentiation to make, because we come across weakness. It's a very common chief complaint that's seen by neurologists, internal medicine doctors, and family physicians. Family medicine doctors. So how do we differentiate asthenia from weakness? In asthenia, it's subjective. The patient has a perceived lack of energy. So what is dropping? Person's energy is dropping. But when you assess through the physical exam, the patient's muscle strength, when you ask patients, squeeze your fingers, they can squeeze them, even if briefly. They can give you a 5 out of 5 strength, 5 out of 5 squeeze. And there is no focality in the pattern of weakness, and also anorexia is a usual feature of asthenia. There is no respiratory involvement, and potential causes can be something as simple and as common as a bad flu, cold, or COVID, to electrolyte abnormalities and endocrine disorders. In the weakness category, the weakness is neurological and the perspective is objective. So the patient doesn't only feel weak herself, but when we assess the patient's weakness, we see that the patient is either dropping objects or oneself. The muscle strength is less than 5 out of 5, and there are usually accompanying features of focality in physical exam, like we saw in our patient, which doesn't seem like she had focality, but there is, because the weakness in our patient was sparing the face and just involving the extremities. And there's also accompanying sensory, autonomic, or cognitive features. And anorexia is an incredibly unusual feature of neurologic disease and supports asthenia over neurologic weakness. And then potentially there's respiratory involvement, which is really important because when there's such an extensive neurologic weakness, instead of localizing the lesion, we should first think about the morbidity. So we can assess if there's respiratory involvement in patients experiencing neurologic weakness. We would like to check the diaphragm, but it's hard because we don't have direct access to diaphragm. So we check the neck extension and flexion, because neck extensors and flexors are innervated by the high cervical nerves, and that also innervate the diaphragm. So that's why we just use neck expansion and flexion as a proxy for checking the diaphragmatic strength. And the potential causes of weakness are usually neurological. And since we have a neurological syndrome at hand, we always resort to the localization times time course in order to guide ourselves to navigate the neurology differential diagnoses. And in this patient, for localization, we can use the physical exam findings. And so what in the physical exam would tell us, would help us localize the weakness of this patient. So pattern of weakness being distal versus proximal tells us helps us localize the pathology, different parts of the neuroaxis. Also, pattern of weakness being symmetric versus asymmetric holds a lot of power and information. And reflexes are also very important. Upper motor neuron pattern with Babinski and Hoffman versus decreased reflexes in lower motor neuron diseases. And also, when we have weakness, we should ask if there are other features present or absent that could help us localize the weakness, where the weakness is stemming from in the neuroaxis. And so whenever we have symmetric weakness, like in this case, like in this patient's case, we should first think that, like, if there's symmetric weakness but no loss of cortical functions, then the possibility of brain disease decreases, because it's hard for all four limbs to be involved by a lesion without affecting the cortical functions to be present in the cerebrum or spinal cord. Because if the lesion was in the spinal cord, then the DTRs would not be preserved, and we would see urinary and bowel incontinence. But in this patient, we didn't see such findings. So the possibility of spine disease decreases. And then when there's no loss of cranial nerve functions, possibility of brainstem disease decreases. And when there is a positive sensory component, what I mean by that is when there's like pain, paresthesia, so extra sensory findings out of the normal, then possibility of myopathy and postsynaptic neuromuscular junction disease decreases. And time course is always, it provides us clues about the possible etiologies of weakness. And we divide the time course into hyperacute, acute, subacute, and chronic categories. And each of these tell us the time course and tempo of the clinical syndrome tells us what are the possible etiologies could be. And so in our patient's case, we had weakness and sensory symptoms in all four of the limbs, and using the clues for localization and time course and labs and imaging, we were headed towards a peripheral process. And this is the topic that I want to delve into further, polyneuropathy. But before talking about polyneuropathy, we should talk about what peripheral neuropathy is, because peripheral neuropathy is usually used synonymously with polyneuropathy, but peripheral neuropathy can actually refer to disorders that are disorders of the peripheral nervous system, including radiculopathies, and it encompasses mononeuropathy multiplex, and polyneuropathy. And so what peripheral neuropathy is that there's sensory, motor, and or autonomic dysfunction in more than one or more nerve. And in mononeuropathy, we have a single nerve affected. And this is usually due to compression, trauma, or entrapment. And as an example, we can think of carpal tunnel syndrome here. And in mononeuropathy multiplex, we have multiple individual nerves affected simultaneously or in sequence. And this is usually due to a vasculitic process. And as an example, we can think of polyarthritis nodosa, and the clinical presentation in patients with mononeuropathy multiplex is usually an example for that could be a wrist drop and foot drop at the same time. Two individual nerves, they are not anatomically related, but the pathology is seen in both of these nerves, either subsequently or simultaneously. And then in polyneuropathy, a way to categorize polyneuropathy is by using EMG. So EMG is a really powerful tool. It's just like POCUS, and it can be used as an extension of physical exam. And it gives us a powerful clue about whether the polyneuropathy process is axonal or demyelinating in nature. And we can use the time course to further inform our differential diagnosis once we decide if the polyneuropathy is axonal or demyelinating in nature, and we'll talk about this in my next slides. So let's talk about how we define and how we differentiate polyneuropathy from mononeuropathy and mononeuropathy multiplex. So there are three cardinal rules of polyneuropathy, and probably, as most of you know, we coined the three cardinal rules of polyneuropathy in three S's. So this is sensory dominant, usually slowly progressive and symmetric. Those are the classic features of polyneuropathy. And why we have three cardinal rules of polyneuropathy? Because chronic axonal polyneuropathies, one of them being diabetes, is one of the most common type of, it causes the most neuropathies are caused by diabetes, like very, very commonly. That's why we have the three cardinal rules kind of serving to describe the type of neuropathy that we see in diabetes. When we think about these patients, they have sensory loss beginning usually at the feet, and it slowly ascends, an increase in severity in the legs before involving the hands and the upper extremity. And then the neuropathies that do not meet the criteria of the three cardinal rules of polyneuropathy are the ones called atypical neuropathies. And they are coined in the framework of ABC plus heavy metal. So you can just remember this and remember the atypical neuropathies. A stands for AIDP and its chronic cousin CIDP. B stands for vitamin B group deficiencies, and importantly, B6, vitamin B6 deficiency or excess can cause polyneuropathy. So it's important to remember that. And then C stands for cauda equina and Charcot-Marie tooth disease, and H for heavy metal toxicity. And then we have three high-yield diagnostic tests for distal symmetric polyneuropathy in the first pass in all comers. And these three tests are hemoglobin A1C to test for diabetes, vitamin B12 and methylmalonic acid to test for vitamin B12 deficiency, and SPEP with immunofixation to test for gammopathies. And EMG is really, really important here, and it can even be thought of as more important than most blood tests, because extensive diagnostic testing is not necessary in most patients, especially in patients whose presentation is consistent with polyneuropathy, and they have a known reason that could explain why they have polyneuropathy. But if the patient's symptoms are severe, rapidly progressing, and has atypical features like asymmetry, and when there's no clear etiology, getting all the blood tests could not serve for the purposes of high-value care. So EMG and nerve conduction studies could be it's recommended as the first line in evaluation to understand first if the neuropathy is predominantly axonal or predominantly demyelinating. Because if you think about it, if a neuropathy turns out to be demyelinating in future, then there is no need to get a thyroid function test from the get-go. So just performing the EMG and nerve conduction studies at the beginning could guide our subsequent steps. And one of the other most important branching points in evaluating peripheral neuropathy was the differentiating axonal and demyelinating pattern. And we used the NCS, the nerve conduction studies, to be able to achieve that. And what does it mean for a neuropathy to be axonal and demyelinating? So long axons are more vulnerable to be affected by disturbances affecting the axonal transport. And you can think of the axon's function, that's transportation, and the long, and you can think of axonal transport kind of analogously to traffic jam. So if you have a long way to go to your home after work, and if there are problems on the road, on the way, that's affecting the transport, then patients who have a long way to go get affected more. But if your distance from work to home is shorter, then you don't get affected as much from the traffic jams. So just like that, in the axonal transport, when we have a long axon, for example, extending from lumbar spine to the tips of the toes, then this long axon is more vulnerable to get affected by medications, toxins, or other metabolic disturbances that are affecting the axonal transport. And so we first see the disturbance in the feet, then legs, hands, and arms. And when we think about the axon's job of conducting the signal, conducting the neurotransmitter, when axon gets disturbed, we see a decrease in amplitude in the nerve conduction studies. But when we think about demyelinating neuropathies, those affect the myelin sheath rather than the axons. And when you think about it, myelin is everywhere. So this is non-length dependent, since myelin in any part of the nervous system could be affected, in peripheral nervous system could be affected. Then the pathology that presents itself is non-length dependent in demyelinating diseases. And in demyelinating neuropathy, since it's non-length dependent, we can see the upper and lower extremity involvement and proximal and distal involvement at the same time, at the onset together. So demyelinating diseases begin diffusely. And when you think about the function of myelin, they wrap up the axon and increase the conduction velocity, right? So when we have a myelin damage, then we have a decrease in velocity in the nerve conduction studies. And the two most prominent causes of demyelinating diseases are either autoimmune or hereditary, such as Charcot-Marie-Tooth disease. Oops. Okay, and then the world of CIDP. So when we think about CIDP, it's a demyelinating polyneuropathy. And here's the universe of CIDP. The typical CIDP lives right here with sensory and motor findings in distal and proximal limbs and usually symmetrical, which goes on for more than 2 months period. And then we have less common subtypes of CIDP, which are sensory predominant, asymmetric, focal, or motor predominant. And then we have the distal phenotype. So 2/3 of the patients who have the distal CIDP phenotype were found to have the IgM paraprotein. So monoclonal gammopathies can have an intersection with the CIDP, especially the distal subtype of CIDP. And in such patients, when we see the distal CIDP pattern, we should also be suspicious of monoclonal gammopathies causing this picture. And we should check if the patient has anti-MAG antibodies, just to make sure that anti-MAG neuropathy is not at play here. These patients have similar features to CIDP clinically, but the treatment and response to treatment can differ between this group of patients and this group of patients right here in the bigger CIDP universe. And then the IgG4 nodal and paranodal antibodies. So it's important to consider the IgG4 pathology in cases of CIDP, which are severe and characterized by atypical symptoms, such as asymmetry. And there is a lack of response to IVIG. And this is a relatively newly recognized group of diseases, nodopathies and paranodopathies, and they are mediated by IgG4 autoantibodies. And here are the most common ones. I listed them, and I will also show them to you in my next slide. So here's the section of the nerve we are looking at. Here's the axon, node of Ranvier, and then we can subdivide the axon into 3 different parts: paranode, juxtaparanode, and internode. And depending on where these antibodies are, we can see a different clinical presentation. And what the nodoparanodopathy differentiation does for us is that it improves on how we think about autoimmune neuropathies and how we classify them. So it goes beyond the simple classification of demyelinating versus axonal type. And this just makes it easier to understand how the autoimmune process is happening by identifying the specific target antigens in different parts of the axon. And by identifying the difference, the specific antibody involved, this can help us understand the mechanism of the disease better, and it can lead to more effective treatment options, especially B-cell depleting therapies. Because differently than CIDP, these nodopathies and paranodopathies respond to B-cell depleting therapies and not the IVIG, not the conventional treatment for CIDP. And this marks the end of my presentation. So here are some take-home points. Please remember how we differentiate asthenia versus weakness, and then how we locate weakness depending on the pattern, reflexes, plus or minus other features, and using the tempo. And peripheral neuropathy is an all-encompassing clinical entity that is defined as sensory, motor, or autonomic dysfunction in one or more limb. And then don't forget the subtypes: mononeuropathy multiplex, and polyneuropathy. And then in the polyneuropathy universe, don't forget about the 3 cardinal rules of polyneuropathy: atypical neuropathies in the ABC plus heavy metal framework, and power of electrodiagnostic tests in differentiating axonal versus demyelinating pattern, and then the 3 high-yield diagnostic lab tests for distal symmetric polyneuropathy being hemoglobin A1C, vitamin B12, and methylmalonic acid, and SPEP with immunofixation. Here are my references. If you want to do further reading on nodopathies and paranodopathies, I highly recommend checking these resources out. And thank you so much for your time. I hope I was able to teach you something, and I wish all of you a happy 2024.
Wow, Tansu, thank you so much. What a fantastic presentation. You made studying neurology seem easy. It was so inspiring. People loved your presentation. They said they love your problem representation, timeline, and also your traffic jam analogy and your authorial Venn diagram. Congratulations, and thank you so much. And for the next one, we have animal. And in order to explain difficult concepts, she will dissect a mystery of words. Animal, please tell us a little bit about yourself, and you can start on diving in this mystery.
Okay, so a very good morning, good afternoon, and good evening to everyone present. My name is Anmolpreet Kaur, and I'm an international medical graduate from India. And I love doing clinical reasoning, and I thank CP Solvers for this platform. So I'll share my screen now. So my presentation is, in the world of words, I'm presenting to you all the mystery of words. Okay. So I'm presenting the teaching points recap of Ethan's case, which was held on 7th of December, Thursday VMR, and discussed by Dr. Rabi and Noah. So it's been quite some time, and going towards refreshing our memories. Yes, these were the pictures which were shared by Ethan. And as we can see that this patient was a 40-year-old lady who presented with progressive bilateral lower extremity pitting edema for 2 weeks, which she was apparently normal. And as we can see in the pictures, her lower extremity edema was also associated with the presence of palpable petechiae rash on both of her legs and elbows. She had a known past medical history of thalassemia, and the edema was unresponsive to diuretics. Another important thing in this case was her blood pressure at the time of admission was elevated. Apart from this and the lower extremity findings which we saw, her vitals and physical examination was normal. Talking about the basic labs, she had leukocytosis with neutrophil predominance and elevated haptoglobin levels, which indicates she was having some sort of infection or inflammation. And in fact, haptoglobin is also a protein secreted by the liver, which is elevated in states of infection, among other causes. And thrombocytosis is also, it seems like to be reactive to that inflammation only. And she had mild anemia with low MCV. If we remember, she had past medical history of thalassemia, so it just explains this mild anemia. And in fact, there is a good teaching pearl here as well, that in chronic thalassemic patient, we have some immunocompromise in the form of iron overload and functional asplenia. So sometimes they are prone to catch infections. Now, this patient had bilateral lower extremity edema, and given her age, we had to rule out certain things for this patient. What are the three main organs which we see when the patient has bilateral edema? Heart, liver, and kidneys, right? So, and also in thyroid, one of the thyroid diseases, because we have to rule that out because of the mixed edema condition which can arise. So her TROP-I and BNP was normal, ruling out the in most part, the heart causes. TSH and free T4 was normal, and she had normal LFTs with no icterus. So what are we left with? We're left with kidneys. Apart from that, we have one another cause of bilateral edema, that is idiopathic venous stasis. And about idiopathic venous stasis, we have two main characteristics: that it occurs mostly after the age of 50 years, and the edema does not extend above the knees. So these two things go against this criteria. So ultimately, we're left with kidneys. And if we can see in this patient, this patient had a petechial purpural rash, as we saw in that picture, and that signifies it could be a vasculitic rash, which points more towards the kidneys. And in case of hypertension, we usually consider kidney as the main cause. So then what do we need? We need a urinalysis, which in this case showed proteinuria and no hematuria. And there was low albumin and low total protein levels in the blood. So what does this picture look like? This picture with proteinuria minus hematuria and low protein levels paints a picture of nephrotic syndrome. But the rash was vasculitic. It points towards the nephritic picture. So that is something we need to look out for. Now, it's time to dissect some words. So suppose there's a patient who comes up with a rash. Let me just show it to you. Okay, so the patient comes with a rash. In his or her evaluation, we can go for a blanching test. What is a blanching test? We put a pressure on the or on the rash with the hand or the glass, and we see if the rash persists or it disappears, right? So what do we get? We either get a blanching rash or a non-blanching rash. What is a blanching rash? Let's look at it. So we can see the glass test. The rash, it disappears when the pressure is put upon it. So that's actually a blanching rash. And to the opposite, we have a non-blanching rash. When we can see when we put pressure over it, the rash does not disappear. So what could be the cause or the driving factor behind this? In the blanching rash, probably it was just because the blood got displaced inside the blood vessel because the blood vessel wall was normal. And in the non-blanching rash, probably the wall got damaged and the blood was under the skin, which could not get displaced anywhere else. So in the context of rash, we talk about two P's. What are the two P's I'm talking about? That is petechiae and purpura. And what are they? Both of them, they are non-blanching rashes. So let me show you a picture. Here we can see these pinpoint rashes. They are the ones we call petechiae, and the large lesions, that's what we call purpura. Both of them non-blanching. So these were some basic definitions. Let's put the pieces together. From the pictures that Ethan shared, we realized that it was some sort of a deep necrotic purpura. So what could be the possible differentials for that? It could be IgA vasculitis, or it could be infective endocarditis, or it could be cryoglobulinemia. Now going towards the urinalysis, we saw that it could paint a picture of nephrotic syndrome. So if we have to do an infectious workup for this patient, what infections do you think we need to rule out when we think about nephrotic syndrome? So basically, there are mainly 4 infections which we need to consider: HIV, Hep B, Hep C, and syphilis, right? And so in this patient, that infectious workup was done, and HCV and hepatitis B antigen was found to be negative. Apart from that, autoimmune workup was also done, all negative. Rheumatoid factor negative, complement levels negative, they're normal. And after that, again, kappa lambda ratio was normal and no monoclonal gammopathy. Now we see a little something positive here. Cryoglobulin was negative, but cryofibrinogen is positive. And then urine protein creatinine ratio showed subnephrotic range. Renin aldosterone was done in view of the hypertension, which was normal. And the only other abnormal findings which we can see is a positive urine culture and renal ultrasound showing large right and left kidneys. So what was the interesting term which we saw in this slide? That was cryofibrinogen. Let's talk a little bit about it. What do you think is cryofibrinogen? It is a type of cryoprotein which precipitates out of blood at lower temperatures. We also studied about cryoglobulin. So what is the difference between cryofibrinogen and cryoglobulin? Is there any difference? If there is a difference, then only there are different terms. So what is the difference? Cryofibrinogen precipitates only in plasma and not in serum, right? So in this case, we saw presence of cryofibrinogen in the blood, that is cryofibrinogenemia. So basically, what are the causes of this condition? It could be primary or idiopathic, or it could be secondary to some causes. What could be the causes? Could be connective tissue disorders, could be vasculitis, malignancy, or some infections, right? And if we contrast it with cryoglobulinemia, It also presents as palpable purpura, just like we'll see now that cryofibrinogenemia also presents as palpable purpura. But in that case, we definitely see low complement levels, rheumatoid factor positivity. So that's a totally different case. And we see in this case, cryoglobulin was negative. So basically, cryofibrinogen is also found in some of the healthy people as well. Or in other words, we can say that mostly cryofibrinogenemia is asymptomatic, but it can be lethal when untreated. So what do you think could be the main manifestation of having cryofibrinogen in the blood? This patient had cryofibrinogen. What was the main manifestation she came up with? Palpable purpura. So yes, skin manifestations are one of the most common presentations of this condition. And we also see thrombotic events occurring with cryofibrinogenemia. That is why we're saying that it can be lethal when untreated. So how do we treat it? We treat it with corticosteroids plus low-dose aspirin. And in case we identify a secondary cause, we treat that secondary cause as well. Okay, so next, we come back to the case. Skin biopsy was done, which showed bullous leukocytoclastic vasculitis with negative immunofluorescence, and the patient was diagnosed as a case of cutaneous small vessel vasculitis or cutaneous leukocytoclastic vasculitis. So many big words, as I said in this slide as well. So we'll talk about them one by one. Firstly, we'll talk about the cutaneous small vessel vasculitis, and then we'll move over to the cutaneous leukocytoclastic vasculitis, which actually are both the same terms, but we need to dissect them individually to actually understand what is going on. Okay, so first thing first, what is vasculitis? Vasculitis is the inflammation of the blood vessel, and with consequent damage to the blood vessel wall, we have narrowing of the blood vessel and therefore ischemia of the target organ. This definition of vasculitis, we all know. Now, vasculitis can affect a blood vessel of any size, small, big, medium size, any blood vessel in any part of the body. And that is how we classify it. So we classify it based on the size of blood vessels that are mainly affected. And it can be large vessel vasculitis, mainly affecting the aorta and the large arteries. Then it is medium vessel vasculitis, affecting the medium-sized vessels and small-sized arteries. And then we have small vessel vasculitis, affecting the arterioles, capillaries, and the venules. And the small vessel vasculitis is divided into ANCA-associated small vessel vasculitis and non-ANCA-associated small vessel vasculitis. And ANCA, as we know, they are the antibodies directed against some proteins present in the cytoplasmic granules of the neutrophils. Now, another important thing to understand about vasculitis is that vasculitis could be confined to a single organ, causing single organ vasculitis, or it could affect systemically so many organ systems in the body, causing systemic vasculitis. So in the next slide, we're going to study about the systemic vasculitis. Now we can see here, yes, this is the large vessel vasculitis, which, as I said, affects the aorta and its main branches. What are its main types? Giant cell arteritis and Takayasu arteritis. Basically, they're a part of systemic vasculitis, as I said, and affects mostly women. Giant cell affects greater than 50 years, and Takayasu affects less than 50 years. And giant cell basically affects mostly the temporal artery and presents with headache, jaw claudication, polymyalgia rheumatica, like that. And Takayasu arteritis is also known as the pulseless disease. Then we have the medium vessel vasculitis, which affects the small and medium-sized arteries. So what are its main types? We have polyarteritis nodosa. Now about the polyarteritis nodosa, again, a systemic vasculitis which affects many organ systems in the body, but it spares the lungs. Pulmonary artery is not affected. So if renal artery is affected, it can cause hypertension. And if the mesenteric artery is affected, it can cause abdominal pain with melena. And one important point is that in this condition is that chronic hep B patients, they are associated with polyarteritis nodosa. So that's one thing to be looked out in those patients. Then, secondly, we have Kawasaki disease, which is mostly seen in Asians less than 4 years old, and it has its own manifestations like rashes on palms and soles, cervical adenopathy, and symptoms like that. After that, we come over to the small vessel vasculitis. Yes, as we can see, it can affect arterioles, capillaries, venules. So small vessel vasculitis, as we discussed, affects these things, and they are divided into ANCA-associated small vessel vasculitis and immune complex mediated small vessel vasculitis. So ANCA-associated, number one, is Wegener granulomatosis. As the name suggests, it's a granulomatous inflammation and affects the upper and lower respiratory tract and the kidneys. So nasopharynx, lungs, and kidneys, right? Next, we have microscopic polyangiitis, which is similar to the first, but the difference is that it is not granulomatous and the nasopharynx is spared. So it will affect the lungs and the kidneys. Also, it's not granulomatous. And number third, we have eosinophilic granulomatosis with polyangiitis. As the name suggests, it has peripheral and tissue eosinophilia and a granulomatous inflammation. So the first one, it is associated with C-ANCA, and the next two, the second and third, are associated with P-ANCA. We talked about the ANCA-associated. Now comes the immune complex mediated small vessel vasculitis. Just a note here, till now we're just talking about the systemic vasculitis. Now in here we have the Hinoch-Schönlein purpura or IgA vasculitis. It is mostly seen in children, right? And it manifests as palpable purpura, GI manifestations, glomerulonephritis, and joint pain. But an interesting thing in this is that skin-limited IgA vasculitis is more common in elderly. And how do we diagnose it? We diagnose it by that skin biopsy, and it comes out with leukocytoclastic vasculitis with IgA and C3 deposits in the immunofluorescence. And another important thing is that it has normal complement levels, as we can see in this patient, which also had normal complement levels. Second is cryoglobulinemic vasculitis. Cryoglobulin, as the name suggests, cryoglobulin is present, that is deposited. And we talked about Hep B being associated with polyarteritis nodosa. So chronic Hep C is associated with cryoglobulinemic vasculitis. It also presents with palpable purpura. And important to notice that cryoglobulin is positive, rheumatoid factor is positive, and complement levels are low. Right, and the third is hypocomplementemic urticarial vasculitis. That is, as the name suggests, low complement levels and urticaria is present. Okay, so this was about the systemic vasculitis. In it only, we have one variable vessel vasculitis, which can affect vessels of any size. And in it, we have Behçet's disease and Cogan syndrome. This was, as I have mentioned, systemic vasculitis. Now, one thing I have not put any animation on because I really liked it. We're going to talk about the single organ vasculitis, and the patient must have no signs of vasculitis beyond this focus over a period of at least 6 months to be classified as such. So coming over to the same diagram, what could be the types of single organ vasculitis? Today we'll talk about mainly two types, one affecting the CNS and another affecting the skin. Okay, so we have primary CNS vasculitis, which mainly affects the arterioles, okay? And next, we have the cutaneous vasculitis. If we remember, the patient's diagnosis was cutaneous small vessel vasculitis. So finally, we have reached the point where the patient was diagnosed in the whole spectrum of vasculitis. And cutaneous vasculitis affects mainly the venules. And that's why we call it cutaneous small vessel vasculitis. Right? So finally, we've explained one part. The second is your leukocytoclastic vasculitis. So about that, we have, if we dissect this term, we have leukocyte, that is neutrophils, and that is neutrophilic infiltration within or around the vessel wall, and clastic, which means breaking or crushing, disintegration of neutrophil nuclei into fragments or nuclear dust. So that's what we see on histopathology. Now, one very important thing about leukocytoclastic vasculitis is that it is not a diagnosis per se. It is a histopathologic description of a rash which is seen under biopsy. So that's what is basically mentioned. And we diagnose it on histopathology, and the main presentation is palpable purpura.
Excuse me, Animal, just for the sake of time, I would ask you to pass quickly for the last slides because we still have Gia's presentation. Thank you.
Okay, so we'll skip over this slide. So there are some causes of leukocytoclastic vasculitis, which are ANCA-associated vasculitis, which we have discussed. GPA, yeah, all of that. ANCA-associated vasculitis, immune complex vasculitis. These all can cause leukocytoclastic vasculitis. And then it is associated with systemic diseases like rheumatoid arthritis, SLE, Sjogren's, and sarcoidosis, among other causes like drugs, infection, sepsis, neoplasm. So basically, all of these are causes of leukocytoclastic vasculitis. So how do we diagnose it? Basically, the cornerstone of diagnosis is skin biopsy with direct immunofluorescence. And the important thing is that the timing and the location of the biopsy are critical in obtaining the diagnosis. It should be within 48 hours of the occurrence of rash. And location, it should be at the peripheral margin, just the junction of normal and not normal tissue. And it should be performed before starting steroid therapy. So these are some of the things which can affect the diagnosis. Since this patient we have had negative immunofluorescence. And the treatment, if it's skin limited, we mostly focus over the symptomatic management, like rest, leg elevation, and use of compression stockings. But otherwise, we can use medications like systemic corticosteroids, colchicine, dapsone. And when the cause of LCV is obvious, we treat the secondary causes whenever possible. And it's like withdrawing the drug and removing the trigger. So this patient received hydroxychloroquine, oral steroids, and topical steroids, and she improved with this treatment. So looking back in the retrospect, this patient had palpable purpura, cryоfibrinogen, LCV, evidence of infection, hypertension, and proteinuria, and was diagnosed as cutaneous SVV. So there was an interesting thing I read in Harrison that said conditions that can mimic vasculitis is cryofibrinogenemia. So I wanted to know the relation, if there is any, between cryofibrinogen and LCV. And I came upon some researches, and I'm sharing it with you guys. And it had a middle-aged woman with similar findings for over 25 years with several exacerbations. And a study of 49 patients was done with cryofibrinogenemia. And there also we can see leukocytoclastic vasculitis in many patients. So that was just my correlation with this thing. And just this last line I loved about it is that in patients with otherwise unexplained purpura, determination of plasma cryofibrinogen should be considered. So that's about it. And these are my references. Thank you so much for listening to me.
Thank you so much, Animal. I'm sorry I don't have enough time. I could hear you teaching us like all day long. Thank you so much. Your teaching skills are so natural and everything agree with me because of the comments in the chat. So for the last but not least, we have Gia that got really interested with hematology because we had two VMRs of the same anemia, the same type of anemia last month. And she chose an interesting name for her presentation that is the hemoglobin's rebellion, sickle cell disease. Gia, could you please introduce yourself and start your presentation?
Yeah, for sure. So hello everyone. My name is Jia, and IMG from China. So currently also in application for the internal medicine residency. And today my topics for the teaching points recap is hemoglobins. Sorry. Let me try. Hemoglobin's rebellion, sickle cell disease. And actually, last month, we got 2 cases about sickle cell disease. One is presented by Dr. Kushel, and another is presented by Dr. Mariana. So let's firstly get a very quick review of these 2 cases. Actually, in these 2 cases, the patients both came with a chief complement that can have a very wide differential diagnosis. One is for chest pain, and another is for left knee pain. And then further labs reviewed normocytic anemia, and then they were both diagnosed as sickle cell disease for the first time in their life. And after we got this diagnosis, when we looking back to their history, there are some more clues towards sickle cell disease. For example, in the first case, the patient had a history of cholecystectomy, and in hospitalization, we found the abnormal liver function and also found the pulmonary hypertension. And in the second case, the patient had a history of intermittent swollen, painful hands, especially during exercise. And then finally, for these 2 cases, one was diagnosed as vessel occlusive pain in sickle cell disease, and another is diagnosed as osteomyelitis in sickle cell anemia. So when talking about sickle cell disease, here are several terms we have to understand. Look at the picture in the center of the slide. Here is a molecular of the hemoglobin. The hemoglobin is consisted of 2 alpha subunit and 2 beta subunit. And the beta subunit is coded by the beta globin locus, which is HBB gene. So the HBB gene can has like hundreds of different variants. If a person carries a variant of sickle cell variant in the HBB gene, then we can call it as the sickle cell disorder. And remember, a gene has 2 alleles. And so for another allele, if it is also a HBB variant, then it is called sickle cell disease. If another allele is a normal gene, then it is called sickle cell trait. In sickle cell disease, if it is homozygosity, which means the 2 alleles are all sickle cell variant, then it is called sickle cell anemia. If another allele is a different HBV gene variant, it could be beta thalassemia, hemoglobin C, hemoglobin D, or hemoglobin E variant, then it is called compound heterozygosity, which is lead to the compound sickle cell syndrome. And sickle cell trait, actually it is a benign condition. So the symptoms of sickle cell disease really happened in this condition. Even it can increase the risks of kidney disease and rhabdomyolysis. And here I have a question for you all guys. You can put the answer in the chat. So in the following countries, which of the following countries you think has the highest and which you think has the lowest annual sickle cell anemia birth rates? You can just take a guess and put the answer in the chat box. Okay. I think maybe you may all have some guess in your mind. So here is the data. Actually, sickle cell disease is prevalent in most African countries. So Nigeria actually has the highest sickle cell disease incidence among all these countries. And here in this map, we can have a like direct view of the epidemiology of sickle cell disease. So it is most prevalent in the sub-Saharan African country, and India is also one of the top 3 countries with the highest sickle cell anemia birth rates. And in both North and South American countries like United States, like Brazil, the birth rates of sickle cell anemia is not so high, but not to zero. But in most Asian and European countries, the sickle cell anemia birth rates is nearly to zero. And one thing to mention is the epidemiology of sickle cell disorder is highly related to the epidemiology of malaria, because the hemoglobin A can have some protective function for malaria. And then let's get a very quick review of the pathology in sickle cell disease. So I think most of you already know that when triggered by cold, stress, or dehydration, the hemoglobin A is tend to polymerize and then lead to very important two pathological processes. One is vessel occlusion and another is hemolysis. The vessel occlusion can further lead to the ischemia of the tissue and the inflammatory factor releasing, and the further process of refusion can lead to further tissue damage. And in another hand, hemolysis can not only lead to the anemia and the cholecystitis, and the released hemoglobin in the plasma can inactivate the nitric oxide and increase the reactive oxygen, which can further lead to the tissue damage and vasculopathy. And therefore, in this picture, we can see the sickle cell disease can involve almost all the organs in the patients. In these slides, the text in pink represents the acute condition, and the text in dark represents a chronic condition. So the vessel occlusion can happen in the brain, caused to the stroke, can happen in the heart, caused the myocardial infection, and the infection can also involve in other organs like spleen, like bowel, like renal and bone. And in the long term, because the repeated micro occlusion in the vessel and the refusion, this process can repeat again over and over again, which can lead to the tissue damage and the organs dysfunction. Therefore, patients can have some chronic condition like the neurocognitive dysfunction in the CNS, heart failure, and functional asplenia, and also the liver or renal injury. And one thing to mention is in the compound sickle cell syndromes, all these clinical manifestations can appear, but it is very different in terms of severity and frequency, depending what kind of HBB gene variant the patients carry. And here I mainly want to talk about the two clinical manifestations of sickle cell disease. One is the vessel occlusion pain observed in our first case. So this vessel occlusion pain can appear as acute episodes, but can also appear as a chronic pain. And in acute painful episodes, it was used to be called sickle cell crisis. And as we mentioned before, can be triggered by cold, dehydration, alcohol, or even menses. And it can be observed, reported by patients in their back, chest, and extremities, especially the hands and feet, are the most common reported sites in children. And it started as early as 6 months and can last throughout the life. Every episode is different in terms of severity and frequency. And the chronic pain can have more mechanisms like the central sensitization, the changes in the opioid receptors expression. Therefore, the pain management is a very hard and tough topic in this patient population. And this pain can also contribute to the mental distress in patients and highly influence their quality of life. And in our second case, we got a patient with osteomyelitis caused by salmonella. So in sickle cell disease, this patient population have a lot of risk factors for infection, like hyposplenism, altered immunity, and because most of them have to receive chronic blood transfusion, they have catheter in their vessel, which definitely increase the risk of infections. And specifically, patients with sickle cell disorder tend to be infected by encapsulated organisms like strep, pneumonia, H. influenza, and salmonella. and bacteremia, meningitis, and osteomyelitis are the most common infection observed in sickle cell disease. And on the other hand, the viral infections is usually more malignant and virulent in this patient's population. For example, the parvovirus are more likely to trigger the bone marrow suppression in this patient's population, and the patients with sickle cell disease who infected with COVID-19 have a higher mortality and morbidity compared with the general population. And interestingly, although we mentioned the hemoglobin A has a protective function towards malaria, but the patients with sickle cell disease can also infected with malaria. And because of the overlap of epidemiology, malaria is the most common reason for hospitalization for children under 5 years old with sickle cell disease in the endemic area. And here I want to give a very short introduction about the treatment. Treatment in sickle cell disease is currently still very limited. The newborn screening and the preventive antibiotics use and vaccinations is recommended in the endemic area. And otherwise, the blood transfusion and hydroxyurea are used to lower the ratio of hemoglobin A, and then it can prevent the complications of sickle cell disorder. And for the curative options, only stem cell transplantation and currently the gene editing technology are used in clinicals, but they are very pricey and not available for all the patients. And so, therefore, there are many issues in the accessibility of the healthcare in sickle cell disease patients. For example, because most of the endemic countries are underdeveloped countries, so the newborn screening is still limited or lacked in this area. Currently, only the USA and Brazil are the two countries with nationwide newborn screening. And you can see the blood transfusion, hydroxyurea are very pricey and not accessible for all the patients, not to mention the stem cell transplantation and the gene editing. And therefore, very sadly, in Africa, the mortality of sickle cell disease can be 90% among children under 5 years. And even with the quality medical care, the life expectancy is still reduced by 30 years. And so here is some take-home points. In today's recaps, we talked about the sickle cell disease, which includes the sickle cell anemia and the compound sickle cell syndrome. And then we have a quick review of the pathological process of sickle cell disease and the different clinical manifestations in sickle cell disease. Especially, we talked about the vessel occlusion, pain, and the infection. And we also introduced a little bit about the epidemiology in sickle cell disease and the limited treatment. And here is a reference I used when preparing for this presentation, and I highly recommend the second, third, and fourth review about sickle cell disease. They have very wonderful pictures and tables for the sickle cell disease. And for the slides template and figures, I give credit to the website SlideSco. If you have any questions, you can put it in the chat box. And thank you for the listening for today's teaching points recap.
Thank you so much. It was amazing. It was so educational. It was easy to understand everything you were saying, and you could like reveal sickle cell disease in a really smooth way. Thank you so much. And since you don't have any questions, we're gonna end this session today. Thank you so much. Thank you for our presenters, and thank you so much that attended this section today. See you next month for another VMR recap, and see you tomorrow for a traditional Wednesday VMR. Thank you. Bye.